So my name is Larry Gant. I'm a professor of social work here at the School of Social Work, University of Michigan, and I'm also a professor of art and design at the Penny W. Stamps School of Art and Design, also here at the University of Michigan. Well, it's basically what happens when people don't get accurate information or when they get disinformation about certain kinds of medication designed to do a really good thing, which is to reduce pain and to reduce unmanageable pain. So, one of the aspects is that we all know this is that, well, some of us know this anyway, is that under real, cautious, very strict medical guidance, opioids can be useful in pain reduction, but the underscore is under very strict medical attention and guidance. They're not designed to be used indefinitely because of the addictive potential. Commercial manufacturers of opioids have acknowledged the addictive potential, and they've come up in the past with really unique strategies, like a kind of a grid that was supposed to be a good time release for some opioids about 20 years ago. And the manufacturers said, "Oh boy, we're really going to, cheat addiction because we're going to have this grid built into the pills that will require a time release." Well, it didn't take too much imagination for people to say, if we squash the pills or mash the pills into powder, guess what? The grid that was kind of installed on the pills goes away, and all of a sudden we can use those and we can get high. So a lot of hundreds of millions of dollars that were spent creating and designing these grids were effortlessly destroyed in a matter of seconds with a good spoon or with two fingers, basically. And so that began the whole challenge of saying, okay, these are really powerful medications. They're being provided with a prescription, but there's not a lot of good guidance into how to use them and when to stop using them and how to dispose of them once they are of no longer use for those individuals. So those are already hallmarks of that can lead to addiction and can lead to abuse as well too. If you don't provide people with a way to get rid of the medications, if you don't have really clear guidance for when to take them and when to stop taking the medications, I mean, all of those are hallmarks leading to possible misuse and abuse. And we see that in the opioid addiction and crisis right now. Well, epidemics like the opioid epidemic impact rural communities and urban communities, and sometimes it's the same, and sometimes it's very, very different. One of the first responses is who calls this an epidemic and who defines this as a problem? And what kind of problem is it? So, in urban areas, opioid addiction has historically been framed as a crime and as a crime that deserves sanction and punishment and incarceration. However, if we look at the current response to the opioid crisis in rural communities, the frame is completely different. It's an issue of education, it's an issue requiring therapy. The assumption is that we are so sorry that you got addicted to these medications, but it's not your fault. You certainly shouldn't be convicted or arrested or incarcerated. You need therapy. And so there's a really interesting kind of privileging of the response, the judicial response, the legal response, even the social kind of presentation. It's very, very different. The people in rural communities that face addiction with injection opioid use are seen as victims that require therapy. In the urban areas, they're still seen as criminals who engage in illegal transactions, who pretty much deserve what they get in terms of arrest and incarceration. So you've got those two differences. I think what has happened, for better or for worse, is that the rural communities where I work, the prognosis for the opioid addiction is positive. Why is it positive? Because no one's been criminalized. The whole process and the whole framing of the issue is not seen as a criminal enterprise, but it's seen as people who just made bad mistakes and who need therapy and who need counseling. So there's a lot of positive spin on dealing with this as an issue, as a crisis where the people are deserving and worthy of response, of engagement, and not ostracism. So when I do my workshops and presentations across Michigan, I often say that one advantage is that people right now in rural communities have the reality that they are not seen as criminals, neither by local, municipal, or by the state government, so they can get help. So it's framed very, very differently. You have judges that have stepped down from being judges in rural communities and been more of counselors and trainers. Because the thought is, my gosh, without education, we're training people that are going to be killing themselves, and that's not right. You have grandparents who are working with their grandchildren because the parents are having problems with addiction. But the grandparents are valorized in terms of being saviors of the family, and isn't it great that grandparents are stepping in to raise children? So different frame that way. Even from the state, there's an increase in passage of real positive laws. For example, the Good Samaritan policy, which basically will not require that an individual who brings a friend in who's overdosing on opiates to an emergency hospital, that person will not be charged with the crime of aiding and abetting. Now, previous times, that person who brought their friend in, who was convulsing to an emergency room, would also be charged as an accessory to the crime. No longer. So you've got some really interesting pro-social policies. Finally, and I think what is most interesting, the whole notion of the legality of syringe exchange, because there's a lot of problem here where people are injecting the opioids. And so the whole notion of syringe exchange is being seen as a positive step, not as one that challenges moral authority. And so what I will say to many audiences, hey, for the first time in a long time, you've got the government working with you to, on the positive side of providing counseling and therapy and resources to the people that have these problems. It's seen as something that shouldn't happen to anyone. And so the laws are increasingly on your side. Even the states, for example, are really trying to respond to the manufacturers of the opioids and coming up with stiff requirements limiting the access of writing prescriptions for opioids. So that's coming from the state as well, too. So there's a lot of positive response that we see. And it's going to be easier to have that impact people in rural communities because there are less people there. It's a smaller community. There's less of a space between people on the street who are addicted and going to agencies and programs. In urban areas, it can be a lot more complicated. But I think the prognosis in rural communities is going to be very, very positive. In urban communities, maybe a little less so, although the laws that the governor signs are effective statewide and not just county by county. So what I've seen in some areas, for example, Flint and Detroit, is that there is a reluctance on the part of certain authorities not to charge individuals. They want to charge the individuals because that's what you do with people of color, unfortunately, in urban areas. But there is a reticence in saying, well, you really deserve treatment. And it's so painful to see these people trying to, say, you deserve treatment, not arrest, not incarceration. So I think overall, this time, the response to the opioid addiction crisis is going to be a lot more positive, is going to focus a lot more on counseling and treatment, and a lot less on incarceration and imprisonment. Certainly, if we're thinking about alternatives or additional kinds of responses that don't come through the province of legal or of identified and funded community agencies and service organizations, that don't come through hospitals per se, or through law enforcement, there can be a number of those. Now, one of the really interesting possibilities are programs like Gospel Against AIDS, which is a mobile counseling and testing opportunity resource that goes to communities and kind of meets the need where in the communities. So at local pharmacies, Walgreens drugstores are a good example of that. And what happens is that there's a counseling and testing opportunity, but it's set up in a very, very festive way. So even the counseling and testing environment is set up as a party. So we've got music coming out, we've got entertainers that are there, we've got art exhibitions, ways to participate. There are prayer vigils for those that have an orientation toward a faith kind of response or faith kind of counseling. That is there. So the framing is very, very different. It's a norming saying, of course, there's not a problem here. We're operating testing and counseling out of your local pharmacy. Okay, not the hospital, not an odious kind of location there. So please come in. We've got music here because you want to have music that makes people comfortable, that relaxes people. There's also faith community as well there. So it's a different kind of an approach and an engagement. Very much kind of a harm reduction approach, an affirming approach, saying, listen, this is an issue. We'll get through it together. There are ways to come. And so the music is full of empowerment and uplift and community of norming. It's all right. If you get tested and you test positive, here's one response that can happen. If you get tested and you're negative, not infected, this is another issue. And here's a lot of information. So whether it's around STDs or sexually transmitted diseases or HIV or AIDS, or whether it is dealing with other kinds of co-occurring drug abuse. So, in addition to opioids, people may have an alcohol problem or another prescription medication problem. And so they provide kind of one stop shopping for a variety of kinds of resources and a variety of opportunities. That is really, really exciting to see. It's funded very, very modestly. But what we see is that when programs like Gospel Against AIDS go into different communities, they often show people in those communities, churches in those communities, art programs in those communities, hey, this is a possible thing that can really happen. So if you work together with your local testers and counselors and have testing and counseling at a neat space, at a kind of a cool community space where people go anyway, that you can also reduce the bar on people kind of going in to a hospital facility, a police department, and request that and to request testing, to request help in a non-stigmatized way, where basically the route and the access to care and to testing is very, very low and very positive. What more publicity around the state options, the legal options. People are still under the mistaken impression that if they are involved in opioids, then they're going to be arrested and incarcerated immediately. That's not the case. What I'd like to see, especially in urban areas, are more resources for therapy, for counseling, both professional as well as lay audience and ministerial clergy as well. If we can get more of those out into the open and more accessible, that I think will be really very helpful. More engagement of communities of faith in neighborhoods. In a lot of urban spaces, these faith communities, the churches, the temples, the synagogues are often the last institution that's a viable institution in many neighborhoods. And they can be outreached, they can be engaged, they can be helped to basically be that kind of beacon of light and also frame it and identify the issue of addiction drug use with opioids as a critical issue, but as one that can be responded to. The Gospel Against AIDS also works with faith communities to help them galvanize and create these kind of communities of care, working with clinics, working with outpatient centers, working with hospitals, law enforcement if need be, emergency care as well. So Gospel Against AIDS trains churches to organize these communities of care and communities of support. And so I would wish for more resources that could basically allow this program to really be implemented and replicated in a real-time basis in a number of large urban areas, small urban areas, and then also in rural communities as well too.